Hi, everyone. Thank you so much for joining. We're kicking off Breast Cancer Awareness Month with an empowering discussion on breast cancer risk factors. So, how genetic mutations can impact the likelihood of being diagnosed with breast cancer and what you can do about it. So, just this morning, BCRF announced $70.3 million in scientific grants to more than 260 investigators across 15 countries. We're very excited to kick off the month with this exciting news. And we thought, what best way than to help our audience and people who are joining today on becoming empowered around what to do when it comes to breast cancer risk. So feel free to submit questions as we dive in, and we'll try our best to get them all in the end. But please remember, we can't answer personal medical questions. There's been a lot of alarming news about growing cancer incidence, specifically among younger people. When it comes to breast cancer, there's been an 8% increase in incidence in women under 40 over the last 10 years. So it's become increasingly important that we arm people with the knowledge on what they need to know when it comes to risk. So we have, of course, this incredible panel of speakers, Dr. Susan Domchak, who is the executive director of the Vassar Center for BRCA at the University of Pennsylvania. Alan Rose, founder of the previvor.org, and of course, Dr. Dorea El Ashri, the Chief Scientific Officer at the Breast Cancer Research Foundation. So let's kick off. Dr. Domchak, one of the most common and tricky questions is who should ask for genetic testing?
Yes, and it's an important question that's changed over time. Sometimes people can have a negative impression of things changing over time, but I like to remind people that's because we gain more knowledge and more understanding, and so we can apply that further. So current guidelines suggest that anybody with a personal or family history of breast cancer under 65, but particularly under age 50, anyone with a personal or family history of ovarian cancer, pancreatic cancer, or metastatic prostate cancer, everyone in that situation should undergo genetic testing. There are other criteria as well, but those are the key ones. And what we've been trying to do over the last number of years is simplify this. It used to be that it was kind of confusing for people to sort out, but we're trying to really simplify it. And I can tell you that although we do quite well in offering genetic testing to people with early onset breast cancer, we don't do a good job offering it to individuals who have a family history of these conditions. And these are the individuals who are at risk and that we could really do something about. So if you have a family history, like I mentioned, please talk to your doctors about the options.
Great. And Alan, I know that you have a really unique story. Can you tell us about your decision to undergo preventative double mastectomy?
Absolutely. Well, I first want to address what Dr. Domchek had just said. I'm one of those unique individuals who I don't carry a breast cancer gene, but I do have a very strong family history. And it was very difficult for me initially to get genetic testing. And so it's very exciting that that is becoming more and more available, particularly to young women or women who are at risk. My mother was diagnosed with the stage 3 very invasive breast cancer at the age of 27. She had a reoccurrence 20 years later in the other breast and unfortunately passed away just shy of her 50th birthday. I was 16 at the time, and so breast cancer was really always part of the conversation in my household. And as I got a little bit older, my dad brought up the idea of having a preventative surgery as an option for me because it wasn't just my mother, it was my grandmother, my great aunt, really every woman on both sides of my family had lost their lives to breast cancer. And I didn't want that to be me. I didn't want my future husband and my future children to know what it was like to live without their wife or their mother. And so I underwent a prophylactic procedure at 26. And it has been one of the most challenging but most rewarding experiences of my life to do that, to feel as if I was able to be empowered in that decision. And I know that there are a lot of young women out there who carry a breast cancer gene mutation or are at high risk and are really navigating that experience, what they want to do, whether they get screening for their, life, additional screening, or they take prophylactic measures like having a mastectomy. But I just feel really grateful that those opportunities are more and more available for young women.
Mhm. And I think you touched on something, and both you and Dr. Domchak touched on something that I think is really interesting, is that our growing knowledge, right? And so where we were even 10 years ago and what we know about genetics is so vastly different than even when you underwent genetic testing all those years ago. So I also wanted to talk to you, Dr. El Ashri, about what we're doing to better understand and identify high-risk patients. I know at BCRF, we're really proud of the Precision Prevention Initiative that specifically is aimed at applying the success that we've had with precision medicine towards prevention. What does that mean?
Right, so I think exactly that. You know, the overarching goal is to bring the impact we've seen in precision medicine in the treatment of breast cancer to the prevention arena. And so that means to bring precision or personalized risk assessment, or in other words, accurately pinpoint high-risk women, and then develop precision risk reduction strategies as well. And currently, our risk reduction strategies are mainly focused around surgical interventions, but through the Precision Prevention Initiative, we have a number of projects that look at risk reduction in other ways. So through other treatments, whether it be chemopreventative treatments or through other ways, perhaps even vaccines, as we have a project in the current round now. And so the only way we're going to make a dent in slowing and reducing the incidence of breast cancer is with this concerted and strategic effort to advance prevention. And that's the goal of the Precision Prevention Initiative. And Dr. Domchak with us today is actually on the steering committee for this initiative, and so gets to see and be a part of this whole process of awarding these grants and projects.
Right, and I think that I find so fascinating, which is the idea that we can better identify high-risk patients and pinpoint who exactly would benefit from early screening and even early intervention to prevent breast cancer from ever taking root. And I know, Dr. Domchak, one of the projects that you were working on is testing vaccines in the population of women that have a BRCA gene. So can you tell us a little bit more about that?
Yes, I mean, first, I do think it's important to emphasize the fact that genetic testing doesn't give us all the answers about who's at high risk. And I think that we've alluded to that here, but I really think it is always really important to emphasize that family history is always important. But other things are important too. You know, many women who develop breast cancer at early ages, we don't find any particular genetic risk. And work is underway to try to find, if you will, that missing genetic risk, but to also understand additional risk factors, particularly for women developing breast cancer before their first screening mammogram, because mammograms give us additional information. But yes, we're very interested with, you know, BCRS generous support over many years, and at the Vassar Center at the University of Pennsylvania, to look at whether you can use the immune system to prevent development of cancer in the first place. And I think if you had mentioned this, you know, 20 some years ago, people would have laughed. That is ridiculous. How can you use the immune system to help either treat or prevent cancers? We now know for sure that the immune system is important, that immunologic approaches are used in many different conditions. In breast cancer, mostly we use this in triple negative breast cancer, particularly early stage triple negative breast cancer. So there's a point of principle there. The immune system can help to treat cancer. But we know from vaccines, from childhood infections and the like, that the best way to give a vaccine is to give it before the disease. You get your tetanus shot before you get tetanus. The way that a flu shot works is before you get the flu. So in breast cancer, it's a little bit more complicated because you have to look at things that are unique to the breast cancer and shared across different breast cancer. So there's a lot of different approaches out there. We're actually looking at something specifically called TERT. And this is overexpressed in 95% of human cancers. And yes, we currently have a study ongoing where we are giving vaccines to healthy BRCA1 and 2 mutation carriers to look predominantly for safety and the development of an immune response. So this is early, but you know, you got to start somewhere, and we're enthusiastic about this approach.
Right. And I think that the idea of just the concept of what you're trying to achieve, I think is what is so hopeful. The idea that we can develop a vaccine specifically for people in the high risk population and prevent the disease. So, Alan, I think that that's sort of what you talked about earlier, is that you knew that you were really at high risk. We don't know everything there is to know about genetics yet. And just as you expressed in your own story, clearly that there is a genetic link that we just don't know about yet. Similarly for me, it's the same. I was diagnosed at age 36 with no genetic mutation, and Dr. Domchek just alluded to this, the fact that there's the majority of women diagnosed with breast cancer don't have any genetic mutations. So I would love to hear about your website, the previvor.
So very excited. Tomorrow, we're actually completely relaunching the platform and really niching down to focus on previvorship, because it is just continuing to grow. And so many women are discovering that they carry a breast cancer gene mutation almost by accident now, with the prevalence of these at-home DNA tests. And they're going on to find out what their ancestry is, and boom, they have a breast cancer gene mutation, and now they are at high risk. And I know for me that when I was navigating this, I knew I was at high risk, but there was no one comprehensive place that women could go to learn about their options, how to be tested, and then what do you do afterwards. You really had to get a PhD in Google to know all of the things that were available to you. And a lot of women were going into doctors' offices, and maybe the plastic surgeon just recommended the one thing they specialized in, but it wasn't necessarily what was most appropriate for their body or their lifestyle. And so what I wanted to do with the previvor is just put everything together in an easily digestible, comprehensive place where women could feel like, okay, maybe I have this gene mutation, but I can now walk through the process, learn about what the options are, and feel empowered in my doctor's office, knowing that they had a voice, they had control, and they were part of the decision-making process. And we see that over and over again with statistics. Women are happier with their outcomes, even if their outcomes are worse, if they feel empowered in the decision-making process. So the previvor allows them to do that.
I think that's key. It's that so much of our decision making also has to do with our mental health as well as our physical health. And even what you were talking about earlier, it's that reassurance. You undergoing preventative double mastectomy had a lot to do with your ability to feel good about your risk. So
Right.
I think that that is also a great thing to touch on. Of course, I alluded to this earlier, but this morning, of course, we announced our plans for our annual grant funding. Dr. Alashri, can you share overall what are BCRF's ultimate goals? Why have we invested an unprecedented amount into scientific grants this year?
Yes, well, it's a very exciting news today, of course. And I think, BCRF has two major pillars of urgency. So the first of these is extending the lives and curing those patients with metastatic breast cancer. Virtually all deaths from breast cancer are from metastatic breast cancer. And there are more women and men living with metastatic breast cancer today. It's surely a sign of clear progress that is being made in more effective strategies that are extending the lives for some women with metastatic breast cancer. But also the biggest urgency to continue this progress and really find therapies that can affect a cure. We need to understand how cancer cells spread, how to stop that spread before it happens, but also how to eliminate those cells once they have spread and eliminate them for good. Our second major pillar then is prevention of breast cancer, as we've been talking about. Incidence is continuing to rise, and even when we can cure metastatic breast cancer, cancers continue to evolve and frankly continue to evade treatments. And so no one should have to go through a breast cancer diagnosis and treatment. So preventing breast cancer is the only way to really reduce the incidence and to continue to bring down the mortality rate from breast cancer. So if we can reduce the number of women diagnosed with breast cancer by more accurately identifying those high-risk patients, as we've been talking about, then we can intervene before breast cancer has that chance to take hold. And finally, overarching all of this is disparities. Breast cancer disparities exist. And for all of the progress that we've made, we have to make sure that it is experienced equitably so that no one is left behind.
Right. Well, very big news coming from BCRF today. And I'm just so excited that we're all a part of it. Dr. Domchak, when we're talking about genetic, I mean, I know that we've talked about that genetic mutations are not the end all be all when it comes to risk. And so there are a lot of factors and important reasons why we all need to be aware of our breast health. But when it does come to genetics, what are the genes? Like, what are some genes that should ring alarm bells if there are some that we outside of just the BRCA mutation? And my follow-up question to that is also, I mean, we discussed this, that the pace of learning is really accelerating over the last decade. And how often, and so therefore, how often should people get genetic testing?
So a lot of questions there. Just to start off, BRCA1 and BRCA2, which just stand for breast cancer 1 and breast cancer 2, because people really aren't necessarily too creative in the scientific field, but they get to where the heart of it is. They were cloned in 1994 and 1995. And it's important to just to say that because we have come a long way in a short period of time, relatively speaking. At the time, we just knew that mutations in these genes were associated with cancer risk, but we had no idea what the genes did. We had no idea whether you could therapeutically target them like we know you can now. We had really no idea of the spectrum of risks. So all of that needed to be figured out, and we've made a lot of progress. Now, we still are relying mostly on surgical risk reduction options, and so we'd like to have more to do there, and we're working on it. But what are the other genes? So there are a number of other genes that have been identified. I think one of the key take homes that I'd like to state is that the risks associated with the different genes are different. So at one point I heard somebody talking about having the breast cancer gene, and I get all like, no, there's not a breast cancer gene. There's multiple genes. And by the way, we all have BRCA1 and 2. They help us. They help protect our cells. They help prevent DNA damage, repair the DNA damage in the cells. It's when you have an alteration, a mutation in those genes that makes them not work. That's the problem. So there are other genes. PALB2 is the closest thing we have to BRCA1 and 2 in terms of breast cancer risk. Its ovarian cancer risk is more modest. There's genes called CHEK2 and ATM, where the breast cancer risk is much more modest. We're talking about for BRCA1, a lifetime risk of 70%, and for CHEK2 and ATM, a lifetime risk of 25%. So if we put those all in the same basket and treat them the same, we're not doing the right thing. There are other genes, RAD51C and D, and something called BARD, that the lifetime risk isn't that high, but there's more of a risk for triple negative breast cancer, for example. And then there's some genes that are really associated with clear, what we call syndromes, that there's more than just breast cancer going on. And that's Li-Fraumeni syndrome with childhood cancers, things called Cowden syndrome, Peutz-Jeghers syndrome. It's not to make it overly complicated. The point is that we know a lot. And since about 2013, if you've had genetic testing, you probably had a more widespread panel. But if there's any uncertainty, you can always contact your provider. You should always have a copy of your genetic testing report. And whenever there's a change in your family history, if there's a new cancer diagnosis, for instance, you should go back to whoever ordered your test and figure this out, because we don't test for every single gene. And there's some rare syndromes that we won't necessarily test in everybody. So it's always worth a review. But my general thing is, if you've been tested sort of again since 2015 or so, and you had more than just BRCA1 and 2, and there's nothing new going on in your family, you're probably okay. If it's been longer than that, or there's something changed in your family, you should go back to your provider.
Mm-hmm. And one question that came up that someone also submitted was, how often, let's say you have genetic testing done, how often should you have your test reevaluated? So looked at again in case we've learned more about sort of the what you were talking about, those other genes with various risk factors.
Yeah, again, if you were tested 3 years ago and you had sort of a 25 gene panel or something like that, which is fairly common, and it was negative, completely negative, not much has changed. So you should have gotten a risk assessment based on that, meaning taking into account your family history, gotten a suggestion for your clinical management. Now, if you had something called a variant of unknown significance, this is a change in the genetic code where we don't know whether it affects the function of the protein or not. A kind of a silly example we give is that the word theater can be spelled ER in the US and RE in the UK, and both of those are fine, and it doesn't affect anything. Just like that, the genetic code can have some variation in the spelling that doesn't matter at all. So we don't want to overreact on these variants of unknown significance, because about 90% of them are going to end up being nothing. Nonetheless, we do ask people who have variants of unknown significance to check in about once a year just to make sure that nothing has changed. Now, we do get those, whoever orders your test should get what we call a reclassification. Like if it changes, they should get notification. But I always say this is a two-way street, because, if you move or change your phone number or something and we can't reach you, that's hard too. So let's make it a joint effort to make sure that these are updated.
Right. I think that for me personally is one of the questions I'm always sure to ask, and Drea knows this very well, because I also similarly had no known pathogenic variants, but had a couple of variances of unknown significance. And of course, then I was diagnosed with breast cancer at the age of 36. So to me, I know the significance because I ended up having breast cancer, but perhaps not. I think it does behoove us to ask.
Yeah, one of the complicating things there is that you can have breast cancer and have a variant of unknown significance, but it may not be why you got breast cancer. And that's one thing that can be very hard to explain. And we've had situations, for instance, in families where there was a variant of unknown significance, but then techniques of genetic testing changed, and that family had something called a large genomic rearrangement, which is always now looked for, but back then wasn't. It was the large genomic rearrangement that was the problem in the family, and the variant of unknown significance had nothing to do with it. And had we acted on the variant of unknown significance, we would have given bad information to people. So it can be really hard. And variants of unknown significance are more common in individuals that are not white or not European white, because just that there's less information known about variation in different ethnicities and races. And so we really are really careful to analyze those, but also to have them updated. So that's the thing, is that it's really, really hard when we have those variants of unknown significance. It can be difficult for patients to understand, and also the uncertainty can be problematic. And so we really try to take some time and explain that. And the most important thing, though, is to act on, if you have a variant of unknown significance, to act on your family history and not specifically the variant of unknown significance.
Great.
May I ask a question?
Yeah, of course.
I have a lot of women in the community who reach out to me who maybe have a very strong family history and feel that they are at risk of carrying a mutation. If they are experiencing pushback from their physician on having genetic testing done, what is something that you would recommend to them, or maybe a resource for them to access if their doctor won't request that for them?
Yeah, so the National Society of Genetic Counselors, just to talk really globally across the country, has a website. And so you can actually go to that website and look at genetic providers near you in your state. We also have that on the Bassler Center website. There's many, many places you can go so they can find a provider, if you will, outside their primary care provider. You can go and meet with a genetic counselor on your own and get that information. Primary care providers have a lot to do. I'm very sympathetic to the volume of things that they have. And so we're trying to help primary care providers not only identify the best individuals for testing, but to take away the burden of how to do it. So we have a lot of initiatives in place. And I think that that's what's important, is that if you have a strong family history and you're not figuring it out, going to a genetic counselor can help. And then any comprehensive cancer center, any large comprehensive cancer center has genetic counseling services. So these are just ways to say, okay, maybe my primary care doctor or my gynecologist isn't concerned, but I'm still concerned. We see people like that all the time, and take them through it. We do a comprehensive evaluation of their family history and offer them then the appropriate genetic testing. There are also direct to consumer services. And the challenge there is just, it can be right for some people. Listen, I just want more people tested. But I think that having a healthcare provider take a careful family history is important, because remember, a negative test doesn't mean that you don't need breast MRIs. So you still need an engaged healthcare provider to make sure that you get the right medical care.
And I do have one, I have a question for you, Dorea, but before we jump into that, we received a question asking about familial degree of separation. And so, for example, when we say family history, what do we mean by that?
Yeah, it gets first and second degree is super easy. If it's a first or second degree relative, you're good. Once you get to third degree relatives, it does in part depend on, that's when we really look at the structure of the family history, for instance. I had a close friend, and yes, there was a BRCA mutation in the family, but it was a third degree relative, and then it turned out that it was clearly coming from the other side of the family. And we figured all that out, but and so it's always worth like saying, okay, this happened to my cousin. And hopefully, and this is where it's important, we need to foster communications across families better. Sometimes, and it's always heartbreaking for me to see, I will see a patient whose cousin knew they had a mutation but never told their cousin. And to me, that's just, oh, that's really tough. So we try to make it as easy as possible, not only for the doctors, but also for patients. Well, I don't know my cousin very well. Okay, we'll give you a family letter. We have to make this as easy as we possibly can make it, to get more testing done in the family. We call that cascade testing. So if I know I have a gene mutation, to make sure that my siblings get tested. Then you test your parents so you know which side of the family it's on, so you know which cousins to go after, things like that. So, but when in doubt, ask about genetic testing. We're always going to happy to take you through it.
Gotcha. And when you say first, second, and third degree,
Yeah.
we're talking first degree, meaning mom, sibling.
Yeah. So first degree are your parents, your siblings, and your kids. Second degree is your aunts and your aunts and uncles and your grandparents. All right. Third degree relative gets you into your cousins, and then you go further out than that.
Great. Okay. Thank you so
And
much.
I can also do like third cousin once removed and second cousin.
No, I think that's really an important question to ask, because I think that comes up a lot for us as well. So, Dorea, I know that we wanted to also talk about not just genetic risk. Of course, we know genetic mutations are a small fraction of the population of women that do get breast cancer. What are some other risk factors that women should know about?
Well, I think, as we talked about for the Precision Prevention Initiative, one of its big goals is to come up with more personalized risk assessment tools. And so some of those could be getting a mammogram with AI, where with AI and mammography, it's not only better able to diagnose cancers, but can actually see things in there that can go further and help predict future risk of cancer. And so again, can tell people who are at a higher risk and might need more frequent screening versus not. But there's another thing when we talk about, for example, these susceptibility genes that Dr. Domchek has been talking about, that one mutation or mutations in those one specific gene carry high risk of breast cancer. There's a whole nother series of molecular alterations called single nucleotide polymorphisms, or SNPs for short, which are just little changes in genes. And then in a series of genes that, when these happen, any one of them doesn't really increase your risk of breast cancer that much. But a lot of them in the right combination of genes then can start to elevate risk. And so there's a lot of research going on now, and some of it BCRF funded, trying to get at these polygenic risk scores that look at large numbers of these genes and the SNPs in them, and try to come up then with the score of how many they are and in what combination. So I think along these lines are ways moving forward to add to our risk assessment tools and really get at a more personalized one. Because as Susan said, not everybody has these genes that have been identified, and there's the search for that gene, but there's also this idea that in individuals, it can be a number of genes interacting with your environment specifically that cause alterations that then drive the cancer process.
Mm-hmm. Very fascinating. And I'll just encourage everyone, if you have questions, we answered a couple already, but please feel free to submit them in the chat. In the meantime, I did also want to ask, we're talking about sort of what are some of the factors that influence risk? What are some modifiable risk factors? And I'll start with you, Dorea, as well. What are some of the modifiable risk factors that we know of that impact risk?
Well, I mean, I think we have some very established ones, and they're really, for breast cancer, they're for several other cancers that all fit this profile, as well as for your general health. And they are, to have a generally healthy lifestyle. So that is to get some exercise and move yourself and get some activity every day. And it is to try to have a healthier diet. And that's not to say you have to become vegan, but really try to focus on decreasing processed foods in your diet and move to a plant-forward diet. One potentially easy way to do this is to look at the Mediterranean lifestyle diet and see what's in there and try to follow that, as opposed to trying to figure it out yourself. But along with both of those then is also getting good sleep. And trying to reduce chronic stress. So, acute stress that you have when you have a test the next day or a big presentation at work, that can actually be good for you. It revs up your immune system and it can actually have some positive benefits. But low chronic stress over long periods of time does what actually all of these things, the processed foods and the poor diet and the lack of activity do, increases inflammation. And inflammation is a big driver of disease and cancer and breast cancer specifically.
Mm-hmm. And I'll add something that's been in the news a lot lately is that link between alcohol consumption and breast cancer risk specifically as well. And I know that I don't know how broadly it's discussed, but it's an important one, especially for breast cancer survivors, I would say, people who have already had the disease, to reduce their risk of recurrence.
Yeah, I could just say just a word about that. Yeah, I do think that, the alcohol has been normalized in a lot of ways in the pandemic. People started to drink a lot more. This is what I see in clinic, is that, it got very easy for people to kind of have a glass of wine or two every night. And for women, up to 3 drinks a week, the risk is extremely low. I know they say there's no safe alcohol, but the risk is extremely low up to 3 drinks a week. Up to a drink a day, the risk is not very high, but more than that, the risk really goes up. And I'm not sure people necessarily know exactly what a pour is, how much a glass of wine is. And so, a simple way to do this, again, we're not trying to tell people to be teetotalers, but just, not drinking during the week and reserving alcohol for, special events and weekends is an easy way to sort of be close to that kind of safer limit. But there's a lot of environmental things that we don't understand very well right now. I think that's a concern that we have about young women in breast cancer. Birth control pills do increase the risk a little bit. It's just a little bit, and let's face it, people take birth control pills for lots of reasons: avoiding unintended pregnancies, cycle control, things like that. So like every medication, there's both good and bad things. But I think that there's a real interest, and again, with BCRF investigators, a real desire to understand the other environmental factors that may be playing a role right now.
Mm-hmm. Right. I think that's what makes it so, when it comes to risk factors, number one, you can do all of the right things. You can have the best lifestyle and it doesn't matter. I mean, of course, I thought I fell into that bucket and still diagnosed with breast cancer. So you can do all of the right things, but sometimes there are factors that are just out of our control that we don't have any control over. But I think you can feel empowered knowing that whether you've had breast cancer or not, there are some things you can do to mitigate that risk and things you have control over, like diet and exercise. And when we're talking about exercise, the ACS recommends 150 minutes of moderate exercise. That means walking a week, or 75 minutes of high intensity exercise. So just to throw out some specifics there, when it comes to moving your body, just walking every single day can go really far when it comes to reducing your breast cancer risk. So Alan,
can I I'm sorry to interrupt, but I did want to emphasize your point. sometimes when we talk about these types of modifiable risk factors, it can seem like there's sort of, if you will, blaming women for getting their breast cancer. I want to emphasize that that is not at all true. We try to differentiate from populationable attributable risks. That means across the population, how things impact things, and individualized risk prediction. So again, you can do absolutely every single thing right. You could have never been on birth controls, never taken a drop of alcohol, be a perfect weight, exercise, not have a family history, and get breast cancer. It's just that when people ask us back, what are things we can do? These are the things that people can do.
Great, thank you, Dr. Domchek. Alan, it's been about, you said 10 years since your double mastectomy. Can I ask, a decade later, how do you feel about the decision?
I think about this often. There was a period where I think I tried to put sort of the mastectomy in the rearview mirror and have it not be something at the forefront of my mind. But I now have 2 young girls. I'm married, and I spent a lot of time when I first had my surgery. I had this incredible viral moment. I had the opportunity to talk to the world really about the experience, and I always talked about my future spouse, my future children, and it's made me tear up. But to be living that future, um, to have made those difficult decisions, to prioritize my health, to be proactive, and to now know that I've done absolutely everything that I can to be around for my family makes me feel incredibly empowered and puts me in a space where, I really regret nothing. I was also able to identify a gene mutation that I carry that increases cancer risk. It might not be for breast cancer, but I was able to do IVF, eliminate that gene. My daughters don't have it. And to remove that sort of sad legacy in my family, I just feel so empowered and so grateful for organizations that are providing that information, providing funding grants so that someone like me, I don't have to know what it's like to leave my children. And it's a very, very empowering feeling. So 10 years later, really looking to the future and feeling grateful that I had that opportunity.
Thank you. That's very powerful indeed. We did just get a question asking about any advice you have for someone who's just undergone a double mastectomy.
Give yourself grace. That is the number one. I remember waking up from the surgery, looking in the mirror and saying, oh my God, what have I done? Even if you have the most incredible cosmetic outcome, I had a great cosmetic outcome, but it changes you, the way that you look impacts how you face the world. And it's a period in time where you have to learn to love a new body. And it's okay to have, I think, those boohoo moments, those sad feelings. And just to say, hey, I've done everything that I can here to be proactive for myself, for my family. That's the number one thing. But realizing that it's okay to have those sad feelings sometimes. And, it's not always the most easy procedure. Not everyone has the best cosmetic outcome. Not everyone has incredible family support. So give yourself grace, take a beat, realize that healing takes time. Sometimes it's a year, sometimes it's multiple years, but there is light at the end of the tunnel.
Thank you. And I'll add to that. I think if you are watching a loved one undergo this, one way to be helpful is to be specific in the way that you offer help. And so offer, like, I'll come and give you a meal. Can I drop off a meal? Can I take your kid on a play date? And so those kinds of specific asks, I think, really take the weight and burden off of the patient who's recovering from surgery or whatever other part of the journey that they're on. So that's one way that I would answer that question as well. So we do have a couple of questions that I think are really interesting here. IVF. There's a lot of talk also in the news recently about IVF and breast cancer risk. Does IVF impact breast cancer risk, Dr. Domchek or Dr. Alashri? Do you have any points of view on that?
So no, the general answer is no. So we just as a reminder, even in individuals newly diagnosed with breast cancer, we very much feel strongly that fertility preservation should be offered to all women who still desire to have children. The techniques related to in vitro fertilization have also changed over time in terms of the medications they use. But the best data that we have for all of these things is from Scandinavian registry data, and there really is no, data that there's an increased breast cancer risk related to IVF procedures. I don't know if Dorea, you had additional comments.
No, I think you just stated it all. And, there are been recent studies just reported too on looking at women who have had breast cancer and the ability then to have children through IVF methods. And again, in the short term, so far, there seems to be no increase.
Terrific, thank you. And sort of along the same lines, we also got another question on breastfeeding and the role of breastfeeding when it comes to impacting risk, and whether or not that is powerful enough or strong enough, as this viewer or audience member asked, whether or not they can be relying on breastfeeding for risk reduction.
So breastfeeding in general does decrease the risk in the general population. I think it's important to remember that there are multiple types of breast cancer, and some of the kind of traditional protective effects related to reproductive factors mostly apply to estrogen receptor positive breast cancers. Things like your early, late first period and early pregnancy and breastfeeding, those are mostly affect estrogen receptor positive breast cancer. And so again, as we talked about the population, from a population perspective, yes, these things, breastfeeding helps. If you specifically, for instance, have a very high risk of breast cancer, say you have a BRCA1 or BRCA2 mutation, then any things like this, these modifiable factors have less of an absolute benefit. So the way to think about it is like most of your risk is from that specific genetic mutation, and these things chip away at the edges, but they don't decimate that risk. So of course we still want people to think about breastfeeding has benefits to mother and child, for instance, or when we talk about healthy diet and exercise, we're also talking about keeping your bones and your heart healthy. So there's lots of reasons to consider doing this, but the general statement can be made that the absolute benefit of these interventions is lower if you have, well, I'll say the proportionate benefit is lower if you have, a high risk of disease. And so I know that sounds kind of counterintuitive, but it's just a little bit harder to overcome that, say, that BRCA mutation. And we don't like people to rely on those types of interventions to say that they won't get cancer.
Great. And speaking of sort of the BRCA1 mutation carriers, we did get a question from a male patient with a BRCA carrier. And I wanted to touch on that, specifically male carriers of the BRCA gene and what the implications are for them and what should they be doing outside of just screening.
Yep. If you line up all the BRCA mutation carriers in the world, half of them are men. Anybody with a BRCA mutation has, for each child has a 50-50 chance of inheriting that mutation. It's not just for family members, so that men should consider getting testing. There are implications for the men themselves. BRCA2 more so than BRCA1 increases the risk of male breast cancer, high grade, more aggressive prostate cancer, and pancreatic cancer. And for those reasons, we do specifically recommend prostate cancer screening. As people may know, it's been sort of all over the map in the general population, but we specifically recommend prostate cancer screening. And such screening, there's ongoing studies, at our center and others, to see if more enhanced prostate cancer screening should be warranted. Pancreatic cancer screening is also recommended specifically, particularly, I should say, if there's a family history of pancreatic cancer, and particularly for BRCA2 consideration of mammograms. So yes, it matters to the men for themselves personally, for the options of reproduction, like pre-implantation genetic testing that Ms. Rose alluded to, where you can screen embryos, and then also the implications for other family members.
Terrific. And this is taking another turn in the conversation, but Dorea, you touched on this earlier when it came to stress and the relationship between acute and chronic stress when it comes to risk. There was a question about whether or not there was this viewer heard that teachers have a higher rate of breast cancer than women in general. I don't know that we know whether or not that's true, but I think I would love to touch on what you talked about, what the relationship to stress is and its impact to breast cancer.
Yeah, so I mean, I haven't seen that particular data that says that about teachers, but there have been a number of studies that show that chronic stress increases the same kinds of things in the blood, factors that can help breast cancers grow are also increased in chronic stress, and also in major depression and major depressive disorder. So it's an important thing to be aware of and to find somebody to talk to relieve your stress, whether that's through exercise, yoga, or by finding someone to talk to, because a lot of these factors that are increase inflammation, and inflammation is a player in many diseases, heart disease, and other diseases, as well as cancer. So I think, and then there have been studies for, especially with depression, with breast cancer patients, showing that treatment of depression can benefit markers in the blood, and can potentially then lead to combined benefit with treatment.
Great, great. I will say, we have a couple of more minutes, so I'll end with a question for each of you, which we'll start with you, Dr. Domchek, as far as what do you see as the most promising future of breast cancer research? I think we specifically we're talking a lot about how do we intervene? What are some non-surgical interventions for high-risk populations? You mentioned that vaccines are still very much in the early stages. What do you predict the future of that from where we are today to when patients can access it?
Yes, there's a term called cancer interception, which is a little bit different than prevention. So prevention is you do or do not do something to prevent the cancer kicking off. You don't smoke, so you don't cause the problems in the cells of the lung to start going. Interception is things are starting, but you're going to intervene before it becomes a cancer. And this is a really important concept as we get better and better about understanding why an individual develops cancer. That might be BRCA1 or BRCA2. It might be polygenic risk scores. If we can understand why that person is at risk, we can develop these targeted interventions in interception related to the precision prevention initiative, obviously. So I think that's the future, is that for too long, we kind of brushed all breast cancer, all breast cancer with the same brush, right? All the prevention was the same, all the considerations were the same, but we know very much now that there are multiple different types of breast cancer. And when we think about intervening on them to intercept or prevent them, they're probably going to require different efforts. So that's what I see as hopeful for the future.
Terrific. And Alan, what about you? What are you, as a patient, as someone who has prevented the disease from your double mastectomy and avoided the same diagnosis at the age of 27 as your mom, what do you see as your most, what do you see as your hope for the future?
My hope is that women are educated about their options and feel empowered in the decision-making process. I think just realistically, we're going to have more and more men and women who are finding out about their genetics. They're going to find out that they're mutation carriers, and figuring out sort of the moral and ethical dilemma around all of that. What are people going to do? What decisions are they going to take? I think if we are empowering the patient, allowing them the opportunity to know what their options are, make an informed decision, we're going to have happier and healthier patients. And I just feel very grateful for the research that's being done to inform people about their genetic futures, really, and how that impacts them. And so that makes me very hopeful. And as long as we're, like I said, informing the patient, giving them the opportunity to be empowered and take the steps they need to prevent cancer, we're headed in the right direction.
Terrific. And of course, Dr. Alashri, we talked about BCRF's grant funding for the year. What do you see as the most hopeful vision of the future.
Well, I would agree with Susan that I think, part of it is in this idea of interception. And as we learn more and more about the very earliest changes that occur and can identify them, that then we can intervene with that. But then I also have to say that having been, a breast cancer researcher for over 30 years myself, and in the area of metastatic breast cancer, and with the urgency there, that I'm also very hopeful that we will be able to not only extend the lives of women with metastatic breast cancer, but affect cure. I think we are at a place where we can almost use, for this incurable disease, almost use the words cure and metastatic breast cancer in the same sentence. We're knocking on that door with the progress that has been made, especially for certain breast cancers. Tremendous progress for HER2-positive breast cancers, and it's starting to extend with antibody drug conjugates and things like that into some triple-negative breast cancers and ER-positive as well. So I'm hopeful that we will get there, and for those who have metastatic breast cancer, be able to affect that cure.
Right. And I thank you for that. And I'll add, as a patient and as someone who's been at watching the Breast Cancer Research Foundation mission unfold for the last 10 years, some of the things that I'm most hopeful about is also what you just talked about, Dr. Domchek, that idea of interception, because I think, we know that incidence is on the rise. We know that younger women like myself, like Alan, and our families, we are the ones that are impacted more and more. But that doesn't mean that everyone under 40 should be screened, right? So the dilemma becomes, what do we do about that? 80% of women under 40 find their own lumps. And I think it's unacceptable that we are left to diagnose ourselves. But what that means is that we have more work to do when it comes to identifying high risk patients, right? And so if we can do that better and intervene, right, and develop those interceptions so that we can pinpoint exactly who is at risk and give them that vaccine or whatever other chemotherapeutic that'll intercept that cancer from ever taking root. That is what I'm most hopeful about, and knowing all of the work we're doing, not only to better diagnose patients, but to better identify those for the women who have breast cancer, have yet to be diagnosed with breast cancer, and hopefully one day the women that are able to avoid being diagnosed with breast cancer. So I think that is one of the things I'm also most hopeful about as well. And I'm watching it all unfold, which is a privilege and an honor. So thank you all so much for joining. We got some terrific questions. If you didn't have your question answered, the first point of resource I would direct you to is bcrf.org. We have a lot of answers on there, so please search there, and always get in touch with us you can email bcrf@bcrf.org. So please, thank you again, Drs. Domchek, El Ashby, and of course, Alan, for your insight today.
Thanks for having us. Thank you.
Yeah.